I have presented a exploratory subgroup analysis on TOPAZ-1 study by primary tumor location at ESMO GI in Barcelona, Spain in 2022. So first, let me show you the primary study design of TOPAZ-1 study. The primary data analysis was presented at this year's ASCO meeting. And TOPAZ-1 study is a randomized, double-blind, multi-center global phase 3 study. Patients with locally advanced or metastatic biliary tract cancer were randomized 1-to-1 to Durvalumab plus Gemcis versus placebo plus Gemcis for 8 cycles, followed by Durvalumab or placebo monotherapy until disease progression or unacceptable toxicities. The randomization was stratified by disease status, initially unresectable versus recurrent or disease, and primary tumor location, intrahepatic cholangiocarcinoma versus extrahepatic cholangiocarcinoma versus gallbladder cancer. The study met its primary endpoint at the pre-planned interim analysis. As previously mentioned in our ASCO meeting, a statistically significant improvement in overall survival was observed with a hazard ratio for Durvalumab versus placebo of 0.8. There is often a delayed separation of immunotherapy plus chemotherapy versus chemotherapy alone. To explore this further, a piecewise hazard ratio was calculated. The hazard ratio for the Durvalumab versus placebo from 0.6 months was 0.91, and from after 6 months was 0.74, demonstrating a long-term survival benefit with the Durvalumab plus Gemcis. This study, the data I presented at ESMO GI is a exploratory ad hoc analysis of TOPAZ-1 study by primary tumor location. As we know, biliary tract cancer is very heterogeneous. The prognosis and the response to treatment may differ by primary tumor location or may by geographic areas. So in this study, the benefit of Durvalumab plus Gemcis was evaluated by primary tumor location and by geographic area. In addition, to assess the combination of Durvalumab plus Gemcis in Western population, the hazard ratio for Durvalumab plus Gemcitabine was calculated from patients enrolled in Europe and North America combined. And as you see, the benefit of the Durvalumab plus Gemcis was seen across primary tumor locations with a hazard ratio of 0.76 in intrahepatic cholangiocarcinoma and 0.76 in extrahepatic cholangiocarcinoma. Please note the hazard ratio for certain primary tumor location in certain geographic area was not calculated due to insufficient number of events. The hazard ratio for gallbladder cancer was 0.94. As you know, gallbladder cancer has a unique geographic distribution by epidemiology study, and due to this increased hazard ratio, additional analysis was carried out for gallbladder cancer. So you can see the combination of Durvalumab plus Gemcis for gallbladder cancer was seen in Asian, Europe, North America plus Europe, with a hazard ratio of 0.82, 0.80, and 0.76. The hazard ratio for gallbladder cancer enrolled in South America was not calculated due to small sample size. However, in this specific patient population, and patients received placebo plus Gemcis outperformed the expectation than other primary tumor location. So in summary, additional analysis was carried out for secondary study endpoint. PFS over response rate and proportion of patients with durable response were improved across primary tumor locations. In conclusion, in this subgroup analysis of the TOPAZ-1 study by primary tumor locations, addition of durvalumab to Gemcis was associated with improved clinical benefit in patients with advanced biliary tract cancer, and overall survival benefit was observed across primary tumor locations.